Good morning, everybody, and welcome to today's Opioids, Overdose, and Brain Injury series, sponsored by the AdCare Institute of Maine and the BIA Maine chapter. Today's topic is community resources for brain injuries and opioids use disorder. The BIA Maine chapter gratefully acknowledges partial support for this training series from the Administration for Community Living, the U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. To ask a question, please type it in the Q&A box of your control panel, and after the presentation, I will read as many of these as possible to our presenters. Our presenters today are Dr. Chrystal Fullen and Patty King. Chrystal Fullen is a clinical neuropsychologist serving the departments of psychiatry, neurology, and trauma surgery at the University of Arkansas for Medical Sciences. In her role, she has developed and co-directs a multi-tiered cognitive rehabilitation program at the hospital to foster interdisciplinary patient and outpatient rehabilitation of cognitive dysfunction, primarily in a TBI population, which also includes behavioral management of post-injury psychiatric symptoms, family psychoeducation to improve recovery, and brief psychotherapy to improve adjustments to injury outcomes. Patty King has been an active member in the brain injury field in Maine for 20 years, working in various rehabilitation settings as a recreation therapist and certified brain injury specialist. She joined the BIA Maine team in June of 2020 as a neuro resource facilitator, supporting individuals with brain injuries and the support systems navigate the resources across the state of Maine. Working in this role under the Administration for Community Living grant, she has built a network of resources and connections with the substance use and behavioral communities. Working alongside the BIA Maine team members, she has helped design and implement a pilot program with local behavioral health programs to identify individuals seeking support who may have also sustained a brain injury. Welcome, Chrystal and Patty.
Good morning. Thank you so much, Peggy, for that. Let me see. All right. I think my slideshow is moving bit by bit here. Thank you, Peggy, for that introduction. I always like to share a little bit about me before I start. If you guys have joined us for the first two presentations as part of this four-part presentation, a few weeks ago, welcome back. We're glad to have you here. And if you are new to the series, we welcome you here as well. So I'm a clinical neuropsychologist. I do predominantly inpatient work at this stage. I specialize not only in traumatic brain injury and acquired brain injury on both the assessment and intervention side, but also in program development for traumatic brain injury and how that can potentially look when comorbid with other disorders. And today we're going to be talking specifically about what comorbid traumatic brain injury and opioid use disorder looks like. That's a picture of me and my dog, Apollo. He comes with me everywhere. He is not with me at work today. Unfortunately, I don't think my boss would like that, but that's my puppy. So some objectives to kind of guide us through the day today. We are going to start with an overview of the previous two presentations. So we're going to talk a little bit about what traumatic and other brain injuries look like, as well as what opioid use disorder and overdose looks like. We are also going to focus on some of the current evidence-based treatment trends for traumatic brain injury and opioid use disorder. And then we are going to hear from Patty, and she's going to guide us through some of the key challenges that are experienced in Maine, highlight some of the statewide resources that are available, and then we're going to wrap up by explaining how you can use some of the information that you've been given today, and how you can integrate that to sort of really design and develop programs or programmatic changes or clinical, treatment changes yourselves, how you can promote prevention programs, and how you can, that's a lot of P's, promote prevention programs, and empower stakeholders. And then also we're going to talk a little bit about just the approach people can take to address gaps and advocacy needs as well. Okay. So I'm going to go ahead and get us started on an overview. If you have been here before, some of this will be some repetition for you, but we've thrown in some additional facts. and helpful information. And then if you're new, we're going to try to do this some good justice as well so that you can get a nice overview too. But if you have any questions, please let us know in that Q&A. So we're going to start with what is a brain injury. So this is a common term that we kind of hear people talk about. And really, brain injury can be used very interchangeably. I think sometimes people will say brain injury when they mean a TBI. Sometimes people will say brain injury when they mean an anoxic brain injury. People will say brain injury sometimes when they mean a stroke. And really, brain injury is sort of part of this term, acquired brain injury, which is an umbrella term. And underneath that umbrella term, we have a lot of different things that can go wrong with the brain. So we have things like infections, things like strokes, tumors, or other space-occupying lesions. We have things like lack of oxygen that can affect the brain and how it works permanently. And then also we have degenerative neurological diseases that affect the brain and then continue to deteriorate how the brain works over time. All of those different things that can go wrong with the brain can fit acquired brain injury if it happens after birth and it's not congenital. So we're going to start talking about one type of acquired brain injury today, hypoxia and anoxia. So hypoxia and anoxia should not be used interchangeably. They actually are different terms and mean different things. Hypoxia refers to a process when there is some loss of oxygen to the brain, whereas anoxia refers to total loss of oxygen to the brain for a given time. There are a couple of different things that can cause this. Cardiac arrest or heart attack is fairly common. Sometimes even really big seizures can lead to this. People who are victims of assault can lose oxygen to the brain, especially if they're choked. People who drown lose oxygen to the brain. Smoke inhalation cases can cause loss of oxygen to the brain. And then, of course, relevant to today when we're speaking about opioid use disorder, people who overdose on sometimes illegal drugs or prescription medication, that overdose can also cause loss of oxygen to the brain. And so the brain really relies on oxygen to work. Everything in the body relies on oxygen to work, of course, but the brain is particularly sensitive to loss of oxygen. So for example, if you for many people have oxygen loss for greater than 30 seconds. In some, maybe not everyone, if you're like an Olympic diver, you might be lucky, but that can create loss of consciousness right there. For a minute or more, people can have cell death. 3 minutes or more, extensive damage to the brain, and 5 minutes or more, really a chance of death resulting from complete loss of oxygen to the brain. There are some unique symptoms that go along with anoxic brain injury. So when people have an anoxic brain injury and survive that injury, we tend to notice some persistent changes in things like executive functioning. So it can be really tricky for them to plan and organize, but also that emotional aspect, emotional regulation, that ability to sort of have good insight into the things that have been different or changed as a result of injury can be absent. People tend to struggle quite a bit with memory. That's because with executive functioning and memory, those are parts of the brain that tend to pull the most oxygen resources. And so when you've lost oxygen, those parts of the brain that control executive functioning, that control memory function, are hit hardest. And then, of course, last but not least, we tend to see this profile, the psychological profile with people who survive anoxic brain injury, where they really, really struggle to find sort of innate motivation. So there'll be a lot of amotivation. You'll see people doing things like, if they wake up and they're waiting for a caregiver potentially to bring them breakfast. They go sit on the couch. They might just stay sitting on the couch unless they're sort of, given another directive or asked to do something different. They don't have a lot of innate motivation to sort of get up and go, which can make treatment, as you can imagine, pretty challenging. They can be in the doctor's office and say, yeah, I want things to be different. Like, I don't like the way things are going, but then really have trouble with follow through as a result of that amotivation. So let's talk a little bit about traumatic brain injury. So this is another type of acquired brain injury. So traumatic brain injury really is a blow to the head from an external force. I always put my favorite definition up here. It's a combo definition from the CDC and the Department of Defense, really just describing that when you have a blow to the head from a jolt or a penetrating head injury, what tends to happen is that the brain's normal functioning is disrupted. And people can have a bunch of different symptoms as a result of that, but typically they have things like alteration of their mental status. They have neurologic deficits, so changes in cognitive functionings would be a neurologic deficit. Another thing would be things like sensory and motor abilities, and then people can have intracranial lesions or bleeding in the brain. So there are a number of different causes as a result of traumatic brain injury. As of right now, the leading cause of traumatic brain injury is still falls. So about almost half of people sustain a traumatic brain injury because of a fall. That can typically affect the tail ends of the population most, so younger kids and older adults, because they're a little bit more at risk for falls because they can be a little bit wobbly, maybe less sure on their feet. But despite the fact that falls are the leading cause and they tend to affect the tail ends of the age spectrum, the age of folks who are most likely to sustain a traumatic brain injury are actually 18 to 24-year-olds, so late adolescents, early adults. And the reason for that is because of everything else on your screen. So things like traffic accidents, assault, being struck by or against an object, at that time when people are sort of starting to drive, allowed to drink alcohol, do all those different things, it can sort of put them at risk for some other causes of TBI. So the impact of traumatic brain injury is a lot. It is one of the leading causes of death and disability in the United States. And even on the milder spectrum, people can still sustain a fair amount of disability as a result of a traumatic brain injury. Of course, it costs a lot. There's a high caregiver burden and an increased risk of comorbid conditions after you sustain something like a traumatic brain injury. So definitely something for people to pay attention to. So let's talk about types of traumatic brain injury. So we said before that you could have sort of like a bump, a jolt, a blow to the head, and also a penetrating brain injury. So the difference between those things is a closed head injury, which is non-penetrating, nothing is coming into the skull, can be sort of a situation where you have something like a fall, right? Let's say someone is on a ladder, they fall off the ladder, they fall and they hit their head against the ground. That would be a closed head injury. So their head is being bounced off the ground, hit against the ground. It's more than the brain can sustain. There could be some tearing, there could be a skull fracture, there could be bleeding in the brain. And that is this first picture right here. So can you guys see my mouse moving? Okay, so if this is your skull right here, this bright white bit, this part right here is actually where the bleed happens. And so that that is bleeding in the brain, and that is a closed head injury. Nothing is leaving the skull. Nothing has entered the skull. This one over here, that's an example of open or penetrating head injury. These are both MRI pictures that are on Radiopedia for people to kind of look at the difference between different types of traumatic brain injury. And this is where you can kind of clearly see that the skull here, the white bit, is broken. And what happened to this person is a bullet. So they got shot. That bullet entered the skull and entered the brain tissue. So that is a penetrating head injury. With penetrating head injuries, one thing to remember is there's an increased risk of mortality. The main reason for that is when something actually penetrates the skull and enters into the brain tissue, you have an increased risk of infection. And because the brain is so contained and so protected by the body and the way that the body is made, it does not handle that external infection well. And so that puts people at increased risk. You can actually see some artifact here, this kind of like starburst right here because of some bullet fragments that are still in that brain right there. Okay. So here's another look. This looks a little bit cleaner and prettier than a MRI. But you might hear some of these things. You know, a patient might come in and say, I had a subdural hematoma. I had an epidural hematoma or epidural hemorrhage. Those are different types of bleeds that happen inside the skull as a result of a closed head injury. Of course, it can be bleeding as well after a penetrating head injury. But if you're looking at a closed head injury picture here, the subdural hematoma is happening under the subdural layer, but it's not happening on or in the brain tissue. It's sort of stuck here between these two layers. Epidural hematoma under the epidural layer, right here, which is this yellow stuff right here. But it's before, actually, sorry, that's the skull, but this is not a great picture actually, but it's before the subdural layer. And then intercerebral hematoma or intercerebral hemorrhage is actually happening in the tissue of the brain. And all of these are dangerous and alarming for different reasons. Something to consider is when you're having any bleeding in a closed system like this, what can happen is that the pressure in the brain can increase. There is no space. So the bigger these bleeds get, if they're not managed, the more pressure happens in the brain, and that can actually lead to fatalities because there's no space. The brain will actually hemorrhage out and down through spaces in the skull that are there. So very dangerous stuff when pressure has nowhere to go. Sometimes you'll also hear about a type of brain injury called diffuse axonal injury. Diffuse axonal injury, or DAI, is actually a pretty serious type of brain injury, and people tend to have pretty significant long-term consequences as a result of DAI, primarily cognitive and psychological. So when someone has DAI, what it means is that the axons and the neurons in the brain are preferentially impacted. Specifically, if this is a neuron, and this is the neuron's head right here, and this is the neuron's tail or axon, as a result of a diffuse axonal injury, the axon can actually be broken off or sheared off by force of an injury, which leaves this neuron depleted and not able to work anymore, unusable. And so diffuse axonal injury can typically happens for a couple of different reasons, but one of the things we commonly see is car accidents. So if you have something like, let's say, a rollover accident, and you have someone rolling and hitting something, you have the brain inside the skull and all the layers of tissue and cerebral spinal fluid that's trying to cushion and protect it. But because of the amount of force on the brain will shift and turn at a rate of speed that is just too much for all of the protection to contain. And it'll actually cause this tearing of neurons, which causes axonal injury. And depending on the grade of axonal injury, that's the sort of extent of damage. So if you hear about someone having a grade 3 DAI, that's pretty significant. It means there's a lot of places in the brain where the axons were sheared off and those neurons were massively affected and are not working anymore. There's a lot of damage in those areas. Okay. So when we talk about traumatic brain injury and even, diffuse axonal injury, all of those different types of bleeds, whether it's open head injury, closed head injury, we always talk about primary and secondary injury mechanisms. So primary injury in traumatic brain injury is when the first initial hit happens to the brain. So when someone is shot, when someone is stabbed, when someone falls, that moment of impact is primary injury. And what primary injury does to the brain is immediately disrupt how the brain works. So if someone has to fall off a ladder, the brain, as it hits, it's gone into DEFCON 5 mode. It's like, oh my goodness, something happened, something is wrong. And all of the typical processes that the brain is involved in change to maximize life-saving, automatic functions like breathing, heart rate, those types of things, if possible. So that brain tissue is disrupted, how the brain works is disrupted. Immediately as well, people can start bruising, they can have those axonal shears, and they can have bleeding. Secondary injury is everything that happens hours to days after that primary injury. So when you have a brain injury, you have that injury at the moment of impact, that primary injury, right? That doesn't mean that your injury process stops. As a result of primary injury, further damage can still continue to happen to the brain. So one of the things that is so important in acute treatment when people go to the hospital for care is managing whatever happened to the brain as a result of that primary injury to minimize how much secondary injury happens, right? So secondary injury involves more swelling. It involves that increased cranial pressure we spoke about, inflammation in the brain, cell death cascades, biochemical changes, neurotransmitter changes, all those different types of things. And the severity of persistent symptoms that are the result of traumatic brain injury are most related to not primary injury, but actually secondary injury and how much secondary injury someone experiences. Okay, so there are also a lot of TBI complications. I thought it'd be important to add this time. We usually say primary and secondary injury, and then we stop. But even after secondary injury, people can have complications in the hospital as a result of traumatic brain injury. So people can have things like coma. They can have cranial nerve injury. Cranial nerve refer to all of the nerves that are housed in the brain and around the face that do different things, like help your eyes move in the directions you want your eyes to move in, help your mouth to move, facial nerves that give you feeling in your face. And a lot of times in traumatic brain injury, people can have cranial nerve injuries. Common ones tend to be the ability to smell and ability to taste. Those nerves actually run underneath the frontal lobe. And when people have frontal lobe injuries, which are actually really common, they tend to damage their cranial nerves as well. And the really upsetting thing about that is people will have their first meal in the hospital when they're cleared by speech therapy to swallow again. You won't be able to taste anything. Which can be very, very devastating when all you wanted was a cheeseburger and you've gone through so much and you can't taste your food because you've lost your ability to smell. Can be pretty traumatic. So people can also have things like seizures. Many people, up to 70%, especially if they've experienced moderate to severe TBI, can experience agitation in the hospital. Of course, spasticity. They can experience, changes to their sympathetic nervous system. Of course, we know about cognitive problems, sleep changes, psychological factors. We'll talk about all of those things, but quite a bunch of different things can go wrong and complicate the picture after traumatic brain injury. Okay, what are the symptoms following traumatic brain injury? So they are varied. Always say traumatic brain injury has multi-system symptoms. And the reason I say that is because the brain controls all of the body systems, right? So any of those body systems can be impacted after a TBI. So we tend to see somatosensory changes. So people will have things like headache, fatigue, particularly the first 3 months after injury for both of those things. They can have changes to any of their sensory systems, vision, hearing, and so on. People can also have motor changes. So they can have things like weakness or inability to move one side of the body, They can have slowed performance, challenges with coordination and balance, changes to their ability to speak clearly. They can have some slurred speech that is persistent. Of course, on the cognitive side, these tend to be the most debilitating symptoms following traumatic brain injury, and they kind of hang around. So they need lots of attention, lots of rehab to help. Attention and processing speed tend to be primarily affected no matter what type of injury. So no matter if it's closed or open or DAI, people tend to have attention and processing speed changes. Many people struggle with executive functioning, and that's usually because the frontal lobes are so involved in executive functioning and tend to be most vulnerable to traumatic brain injury. And I think that's just because it's right in the front, and people sometimes will tend to fall forward. And also the frontal lobes are the biggest part of the brain. So it just tends to be more vulnerable because of that reason as well. People also have psychological and behavioral symptoms following traumatic brain injury. They can also be persistent and sometimes get in the way of people's return to the community, primarily those behavioral symptoms. And so a lot of times we have great rehab and great treatments for PT, OT, we have speech, we have lots of things for all sorts of things. We don't have a lot of really robust programming to sometimes target some of those behavioral symptoms unless people are fortunate enough to go to really long-term rehabilitation centers that specialize in that. But the psychological picture can look different depending on the type of injury. People can experience things like PTSD or acute stress. Of course, many people struggle with depression and anxiety following a traumatic brain injury because of some of those neurotransmitter changes, and many people, at least briefly, with some adjustment disorder symptoms simply because of everything they go through after such a massive injury. Behaviorally, a lot of times people will notice things like anosognosia, which is reduced awareness of symptoms. People can also have increased impulsivity. They can have challenges with understanding social cues and social cognition. They're at a high risk for increased substance use, and then, of course, sleep disturbance as well. Okay, super important. This isn't national yet, but we're trying to make it this way. Patty will have to tell me what they say in Maine, but honestly, a lot of times people we'll talk about TBI like it happens that once off, right? That primary injury, and then you're done. We've kind of expanded things for people to understand more about secondary injury and complications and some of the more lasting symptoms, which we just spoke about. But many people feel like your brain heals for X amount of time, and then that's where you're at. And they don't think about traumatic brain injury as a chronic condition. However, more and more research is coming out that's showing that there is a lot more neurological recovery that is possible. And as a result of there being ongoing neurological recovery, we can also then see that there is ongoing active symptoms of traumatic brain injury 1, 2, 3, 4, 5 years post-injury. So really important for people to understand and to advocate for their patients that because TBI is chronic, we need resources to kind of support that. Okay, so let's move on together to do a little overview of opioid use disorder. So we'll start with discussing substance use disorder and some of the causes of that, some of the more unique symptoms inherent in opioid use disorder, and then talk about overdose as well. So with substance use disorder is really defined as an uncontrolled and persistent use of any substance, despite really negative consequences. So continuing to use despite a negative impacts on the body, and then that person's life environment, people that are important to them, and so on. So of course, this is also known as an addiction. We don't use that term as much anymore, but a substance use disorder is, a really complex psychiatric disorder. Although we have a lot of research that tells us about things that make the risk of substance disorder, more prominent. So things like if you have a family history of substance use disorder, if you've had adverse childhood experiences, and the number of adverse childhood experiences goes up, so does your risk for things like substance use disorder. if you've had early exposure to illicit substances, if you have any mental health conditions, if you've had a traumatic brain injury, all of those things can increase your risk of developing something like a substance use disorder. But still, the unique reasons that make people use a substance, despite repeated negative consequences, despite trying to quit multiple times and relapsing, all of that, the exact cause is unknown. I think if people figure that out, they probably figure out substance use disorder, but we haven't gotten there yet. So there are some key features that are required for the diagnosis of a substance use disorder. There are 4 categories. So having impaired control, having social problems as a result of substance use, having dangerous use, so putting yourself in positions where you're either using the substance to the degree that it can be very dangerous for you from a health perspective, or putting yourself in social situations that are very risky and dangerous in order to obtain that substance. And then, of course, drug effect needs to be present as well, which means that a person is experiencing things like intoxication. They're experiencing things like tolerance, so needing more and more of the drug to have that desired effect, that intoxication effect, and then also experiencing withdrawal or a lot of different physical, mental symptoms that are happening because the drug has left the body, left the system, making you want to use it again to get rid of those withdrawal symptoms. Okay, so opioid use disorder is essentially a substance use disorder with the primary substance being used as opioids. So opioids occur, naturally in things like the poppy, and then also are found in a number of different prescription drugs like oxycodone, hydrocodone, morphine, and then also as illegal substances in things like heroin and synthetic illegal substances like fentanyl. So there are a variety of different opioids that can essentially get people into trouble. Opioid use disorder, just like other substance use disorder, is diagnosed after there's a problematic use pattern over a 12-month period. With opioid use disorder, there are some unique differences to kind of look out for and think about. First, with opioids, as opposed to some other substances, people can become physically dependent. So that drug effect component of the diagnosis, they can become physically dependent on the substance in as little as 4 weeks. I always say this when I talk about this, that is pretty much the average length of a prescription of an opioid medication that you might get if you say, let's have, maybe you're doing some gardening. We're doing a lot of gardening now, hoping to get some veggies going for the coming months. But let's say you're out there, you tweak your back, you go to your doctor, it's really bad. Over-the-counter medication's not working. Doctor gives you a prescription for a stronger medication to help knock that pain out so you can get back to your life. Right? Usually people are prescribed 1 a day for a month. And that's all it takes. That's all it takes. There are significant withdrawal symptoms with opioid use disorder. I'll show you guys in a moment. But those withdrawal symptoms, the worse the withdrawal symptoms, the worse that impact is on your body and your functioning, the more the risk of reusing that substance to get rid of those symptoms is going to be. And so with opioid, you have that dependence happening so quickly, and then such significant withdrawal symptoms that people, they really just sometimes cannot help themselves to use again. And of course, as I said, that causes increased motivation to use. So let's look at a little bit of an opiate or opioid withdrawal timeline. If you look over here, you're taking your last dose, and 24 48 hours will pass. You'll start experiencing withdrawal symptoms pretty quickly, depending on if you're taking a long-lasting or short-acting opioid. By 3 days or 72 hours, your physical symptoms are going to be at peak. There's a combination of things that tend to happen for folks with opioids. Obviously, one of the biggest is going to be an increase in pain. and some pain sensitivity as people get used to the opioid managing their pain. So they'll feel like really tremendous pain, motivating them to use again. There's also a wide range of very upsetting and pretty significant gastrointestinal symptoms. So people will be nauseous, they can have diarrhea, they can also experience fever, chills, body aches, or flu-like symptoms as well. Even after a week, people can still be experiencing tiredness, body aches, that nausea, but they can also experience anxiety and irritability. And even 2 weeks later, have persistent psychological and emotional symptoms as a result of not taking their opioid. So pretty significant and long-lasting symptoms that really, really motivate people to use again. It's not easy to stop an opioid. It really isn't. So last time we did this talk, if you were here, you'll remember we sort of did the neurobiology of opioid use disorder and really focused on how opioids work on the brain. What's that mechanism of action? And so today I just wanted to do a quick review of that. So how an opioid works in the brain, how it has this really significant big effect that it does is that opioids imitate neurotransmitters in the brain, and so they work on the neurons like other neurotransmitters that you know about. So serotonin, dopamine, GABA, all those other ones. So there are loads of neurotransmitters on the brain, in the brain. They do a bunch of different things. 60, 70 more neurotransmitters that we have. And so what happens is when you take an opioid, they bind to specific opioid receptors in the brain. And as a result of binding to that receptor, they do a bunch of different things to that neuron that holds that receptor. So promotes potassium conduction. It decreases the action potential of the neuron, which means that it actually stops that neuron from working, which causes a blocking of pain signals. It can also help release dopamine in the brain, which is why we have difficulty later on after long-term use with things like learning, things like our understanding and our ability to work with the idea of reward, which makes treatment really difficult because of this increase of dopamine that's in the brain always when you're using and then not at all when you're not. It also inhibits calcium conduction. So you have that loss of, neurotransmitters being sent by other neurons. And depending on where the receptors of the neuron is that the opioid is working on affecting, it can cause a bunch of different symptoms that the user will experience pretty immediately. So they'll have like a feeling of pleasure in the body. They'll have a feeling of relaxation in the body. Many people report decreased anxiety. And then, of course, there is a sedating effect on the brain. So people can get a little more sleepy, which tends to make them feel a little bit more chilled out. And then, of course, it also reduces pain as well. So it has a lot of effects instead of just pain management. So what's the impact of opioids on the brain then? What does it actually do after it's acting on the neuron in this way? So from a cognitive perspective, it impairs your ability to learn. It can impair your ability to remember. It can cause poor decision-making and emotional dysregulation. And in long-term use, some of those cognitive problems will persist, especially things like impaired learning and emotional dysregulation. With regards to mood, as we just said, it does create that sense of pleasure, induces relaxation, but interestingly, because it's stopping some other neurotransmitters and working the way that it typically works in the brain, it can increase people's risk of depression, which can also then, because they're looking for that sense of pleasure, looking for that feeling of relaxation instead of stress and worry and irritability and low mood, can also increase risk of reuse. And then from a behavioral perspective, of course, blocking those pain signals. But then over time, as I mentioned earlier, can change people's perception of pain. So as you take this drug that is able to really make you feel good and take your pain away to such a significant degree, once you are not taking it or in between spaces when you're not using it, it can make sort of any tiny little ache or pain feel so much greater than maybe what pain initially felt like for you. And then again, causing physical dependence pretty quickly, which results in cravings and recurrent use. Okay. So some statistics here about opioid use disorder. I think one of the most important things to kind of consider is that there's a pretty high rate of people who are still developing opioid use disorder. Up to 20% of people prescribed pain medications reportedly develop an addiction to those medications. Interestingly, many people with opioid use disorder end up turning to other substances, so they don't stay abusing something like hydrocodone or oxycodone. They tend to turn to things like heroin and other street drugs because it's actually more easily available after providers recognize, oh, this person has a problem. They're maybe overusing this medication. I'm going to kind of take them off of it and give them something else. Well, then that person ends up ultimately having to turn to street drugs in order to fulfill that need, that craving. Also, as tolerance goes up, the more tolerant people become of their medications, the more that they need something stronger, which is why people tend to turn to things like fentanyl after time as well. Fentanyl is like hundreds and thousands of times stronger than typical pain medications, so it is incredibly dangerous. But, you know, for people who have these substance disorders with opioids, it works really well for them and increases their risk of wanting to use something like that. Per CDC, there were 108,000 deaths due to overdose in 2022, so not too long ago. And 3/4 of those were actually due to opioid use disorder. And the reason for that is because opioid use disorder also has a sedating effect on our respiration in our body. So it actually slows breathing to pretty dangerous levels. So if we look at TBI and OUD together, we can see that there's some pretty significant statistics. The first being that about 72% of people with traumatic brain injury are prescribed opioids following their injury. Many people with traumatic brain injuries also sustain other injuries at the time. We go back to a car accident example or falling off a ladder, you can imagine that people can have what we call polytrauma. So they're also having some broken bones and things of that nature as a result of their injury. So people are typically prescribed pain medications to help with that. And people who have more severe medications are even more commonly prescribed opioids. People are also co-prescribed other sedatives like anxiety medications or sleep medications along with those opioids, making the risk of overdose higher. And also, if you think about the traumatic brain injury population and some of those symptoms we were discussing, they can sort of have trouble with impulsivity, they can have trouble with learning, with memory, and also at more risk to misuse a medication accidentally. Essentially, up to 1/4 of people with traumatic brain injuries develop opioid use disorder as a result of all of those things. So I'm seeing the time. I'm going to move a little quickly here to make sure that Patty has enough time for everything she is sharing. As I mentioned before, when you have TBI and opioid use disorder together, the picture can get pretty murky. You can have, you know, this symptom profile with traumatic brain injury that really, really increases your risk of repeated use of opioids. So as I said before, memory difficulties and impulse control difficulties, but also because of the effect of opioids on the brain, you can have a sort of sense of relief, of depression, anxiety, PTSD, and adjustment when taking opioids as well, which really does increase the chance of people misusing them. When people have both traumatic brain injury and opioid use disorder, it can reduce their social support, which can affect their outcomes long term. It can increase people's risk of being injured again, making their cognitive and emotional symptoms and pain even worse. We, of course, have a greater risk of overdose because people are misusing the medication, and they really are not necessarily able to get the care that they need. There's limited access to care and education, and also limited access to programs that are designed to impact both positively. So I think, sorry, my mouse is only moving one of my slides now, not both, and I'm looking at 3 different screens. So let's talk about overdose super quickly. Causes of overdose with opioids, as we mentioned before, is that opioids slow breathing. And as those breathing and heart rates slow with opioid use, people can experience respiratory failure. Of course, there's lots of risk factors for developing an overdose as a result of an opioid. One of the biggest things, of course, is if you have a high dose. So again, as I was saying, fentanyl is super strong. It's about 100 times stronger than morphine, actually. And so if people are transitioning to something like fentanyl because of increased tolerance, that can put them at a great risk very quickly for an overdose. People also tend to sometimes mix alcohol or other sedatives with their opioid, either because they don't understand, or they weren't explained the risk, or because they are developing that tolerance, and that can increase the risk of overdose. People can also have a lower tolerance at a specific time that very accidentally puts them at risk for an overdose too. So for example, if someone is coming out of rehab, if someone is coming out of the correctional facility system, and they go to use an opioid or a street drug, they can be at a greater risk of overdose for just that. So it doesn't only happen to people who are using regularly, it can sometimes happen to someone who just has a once-off use. Of course, the signs of overdose there are a bunch of different ones, but the things to look out for with opioids specifically is, of course, that loss of breathing or shallow, slow breathing. People tend to have pinpoint pupils. They'll go blue around the mouth and skin, lips and nails. And then they are typically unresponsive as well. And so usually what people need to help prevent any kind of lasting effect or death from overdose is something like Narcan, which blocks opioids in the brain from attaching to any receptors. And of course, if anyone is in this position, I always tell people call 911, and they will help people know what to do with the Narcan. This is kind of what Narcan looks like. It quickly reverses opioid overdose. It can be injectable, a nasal spray. Sometimes people need multiple doses. It does have a vomiting and choking risk, so people have to be really careful when administering it, but it's very effective. And there are a lot of initiatives now where they're handing out these packs to help people have them handy to prevent overdose, particularly via fentanyl. So there are a couple of treatments out there right now for traumatic brain injury and opioid use disorder, and Patty's going to talk about the ones that are specific to Maine. But really with traumatic brain injury, I always say it takes a village. There are multiple different specialities and providers that help with traumatic brain injury, from intensive care all the way to long-term resources to target the chronicity of traumatic brain injury. But essentially, we really want to have levels of rehabilitation that target any and all of the symptoms that we described earlier. And we really want long-term options for folks with traumatic brain injury, so that when people have an injury and they have their initial rehab and they go home, maybe they go back to work, and then they realize that there's an issue, that they can come back and have services in the community that help with late emerging symptoms, any symptoms that are exacerbated by stress or overstimulation, and any symptoms that come up due to adjustment to injury, even long term. And then with opioid use disorder. We have, medications that are prescribed and are pretty effective to help people with their substance use disorder. Of course, pairing those medications with counseling and rehabilitation tends to have the most robust effect. So if we think about adding those two things together, what does that look like? Well, it really looks like a four-pronged approach that leans heavily on co-treatment. We can't have just one provider treating people who have comorbid TBI and opioid use disorder. We need to have medication treatments that help with the opioid use disorder, that also help change prescription practices for people with traumatic brain injury, and that promote education initiatives so that people understand the effect of certain drugs, how strong certain drugs are, what makes people more or less at risk for things like overdose, and how to treat overdose. We also need things that are very individualized, like neuropsych assessment, to help us determine if, because of the traumatic brain injury and the complication of opioid use disorder, has had certain impacts on psychological and cognitive abilities. What are they? That way, clinicians can make different adaptations to their therapy, their group therapy, the way they provide education, the way they provide substance use counseling, to be able to target those things so that people aren't missing out on treatment that they're actually receiving because of something like a memory problem. And then really involving support systems as much as possible to help everybody get all the support that they need. And with that, forgive me for going a little quickly at the end. I ran out of time. I'm happy to take questions later on. I'm going to give you guys to Patty. She is going to address some specific things about Maine that are so valuable.
Great. Good morning, everybody. So we're just going to talk about some key challenges in Maine and some of the steps that we're hopefully trying to take to close some of the gaps that are there. So we'll talk about a little bit about the opioid crisis, Maine's rural status, funding sources, health disparities, lack of services, transportation, lack of awareness, and wait lists. These are not all the challenges. Everything is unique. So these are just kind of the few that I've picked to really kind of talk about. So real quick, the opioid epidemic, here in Maine, the non-fatal overdoses by year is here on a graph, and it is declining since 2022. And I think that's in part to a lot of different interventions the state has done, including the options program and some ride-along services with police departments and emergency supports. But the challenges with tackling the opioid epidemic are similar to those for the brain injury services. There's the causation, the opioid, I can't talk this morning, I'm sorry, epidemic has three primary connection points to brain injury: the causation of new brain injuries, the challenges in successful recovery due to the brain injury, and the risk for brain injury survivors to become addicted to opioids, which Dr. Fullen touched on as well. And really what we're evolving here in Maine is really looking at trying to close some of the gaps in successful recovery, and also building some awareness on causation of new brain injury. So here's some maps that I kind of put together. So the first one to the left is from the Maine Drug Data Hub, which is great if you want any data about the opioid epidemic here in Maine. But it really shows the dispersal of support for those with opioid use disorder. And as you can see, a lot of them tend to be southern. The middle of Maine is a little bit bare, and then a few more up north following that I-95 track. And then you kind of can overlay that in your mind to the middle map, which is our pilot sites here in Maine that we're working with under our ACL grant. So we have a smaller cluster in southern Maine and a cluster up north, again, kind of following that I-95 track. But what we wanted to do is really make sure our pilots were spread across Maine's population so that we make sure that we're looking at the needs in all of these different areas. And then the last map is the skilled nursing and outpatient clinics in Maine for brain injury, again, very heavily weighted to the southern part. In Maine, about 40% of our population is along the coast. So a lot of services tend to cluster there. However, that creates issues, which we'll talk about more in depth, of getting those services if you don't tend to live in one of those communities. Funding is another barrier that we work a lot with. Some common funding sources are MaineCare, Medicare, VA, all the various private insurances, and then there are some people who are uninsured or have private pay. Many individuals with brain injuries will fall into the void between needing services but not being able to get those services because they don't, those services don't accept their insurance or they don't have insurance coverage. So a lot of the work we do as NRS is trying to find services that will connect them or helping them apply to other funding sources that may support them. Most long-term brain injury supports are funded by MaineCare, meaning it's only available to those with the lower incomes and limited assets. So that can be a challenge, especially if somebody gets a brain injury, maybe working on the job and they're on workman's comp. They only get this short-term care, and that longer-term rehabilitation is not reachable for them because they made an income in their life and they're above the SSDI standards. Long-term support programs like sober living houses can be expensive and not covered by insurance as well. And long-term supports like case management may not be covered by insurance for opioid use disorder or brain injury. And case management we find is a really key player in a lot of the recovery for both brain injury and opioid use disorder. And then some services are only available under waivers, which can have wait lists that can be extensive. And sometimes that's a challenge, is people are sitting in this kind of hole, knowing their services at the end of the tunnel, but can't get there because of these wait lists. In Maine, it's an estimated 5,500 Mainers experience a traumatic brain injury, resulting in an emergency room visit each year. So again, that's traumatic. That's what Dr. Fullen was talking about, those external forces. We're not talking about the acquired injuries. So that number is likely much, much higher. But we have the data for the traumatic brain injury. So about 1,100 have an inpatient hospitalization stay out of that 5,500. But our real incidence isn't known and is likely much, much higher than that. So Maine's population is about 1.4 million, which again is like smaller than the number of people that go to Times Square for the ball drop every year. So it's really nationally a very small number, but that does put those percentages higher. So those disabled from brain injury, about 27,000. And then disabled from stroke, 28,000. So we're looking at about 40 to 50,000 people out of that 1.4 million that are getting a disability just from those two subsets of acquired brain injury. A little just dollop of health disparities. Just to be aware of veterans, we do have a large veteran population in Maine. Typically, we see brain injuries in that population from it could be the traumatic type brain injuries. If they've served overseas, you may also see blast injuries, but also a lot of veterans coming out may be self medicating because of PTSD or other things. So we may see also some injuries from anoxic or hypoxic injuries due to overdose. The rural population is a health disparity in its own. Again, we talked about 40% of our population is in the greater Portland area. So that leaves a large portion of our state that is rural. And that brings in itself its own challenges. And then racial and minorities. Maine is a very white state. We're 94%, but that doesn't mean that there aren't racial disparities. We have 3 recognized Native tribes in Maine. And some cities have larger populations, particularly like Lewiston, Auburn, of refugees. So we want to take that into, keep it in mind as we're publishing things and making sure that they're accessible to those minorities groups. And then the gender split for Maine is almost 50-50. So we do tend to see more males with traumatic brain injury in our treatment programs. The justice involvement group is also very, very high. Currently in 2022, there's about 1,800 incarcerated individuals in Maine. And the overlap of brain injury and incarcerated individuals is somewhere between 50 and 80%, depending on what statistics you're looking at. So that's, again, another population that likely isn't counted in that overall brain injury number for Maine. So if you're looking at 80% of that, you're looking over 1,000 additional individuals that may either not be counted, don't have a diagnosis, or fall outside of the TBI, but still have a brain injury. Homeless is very similar population that probably we don't have a lot of data on as far as diagnoses. But there's an estimated 2,700 as of January 24 that are homeless here in Maine. I can only imagine trying to be homeless here in the state with the weather and all of those challenges. And you think about number of assaults that may happen, even with the weather, slipping on the ice and hitting their heads, they may not be seeking medical care. So it's not hard to believe that the rate of brain injury is probably very, very high in the homeless population. And then marginally housed, it's really unknown because there isn't much data on that. So wait lists. It's really challenging because when we talk about wait lists, people get really excited because there's hope out there, there's something out there, but then there's this great big long wait time to get there. I always call it the hurry up and wait. You do all the paperwork, you get all ready, and then you're waiting and waiting and waiting and waiting. So that's really challenging. And unfortunately, our brain injury waiver is one of those areas that has a wait list. It has great services once you get there, but there is an extensive wait list. There's just not enough funding or active programs to support the number of individuals that need that. So I think there's somewhere around, give or take, 200 that are getting services on the wait list, and about the same number that are on the wait list still waiting for services and funded offers. Neuro rehab and outpatient clinics, we have 8 in the state with limited space. Some have wait lists of 30 days, some are 3 months, depending again on where they're located and what their staffing and resources are like that way. As we all know, getting good staff and turnover is a challenge here in Maine, making sure we have good quality staff. But also trying to keep them. And working with brain injury is no small feat. Working in overdose or opioid use, substance use programs is no small feat. So it really takes a special breed of person to work there. Few counselors or case managers with training in brain injury is another challenge. And prior to our pilot work, there were no known substance use and traumatic brain injury crossover programs here in Maine. And then recovery beds, sober homes, and MAT programs are limited in the state. There is work being done on several of these points, which we'll talk about in a second. Lack of awareness is another area. A lot of people just don't know about brain injury. They're not aware of it. It's an invisible disability. People just don't see it. And people don't wear name tags and say, hey, I have a brain injury. And they may not even know they have a brain injury themselves. So although nearly 20% of Maine's population is estimated to have traumatic brain injury, finding providers, support systems, and services that account for potential brain injury are rare. Unless it's already living under the hub of brain injury services, a lot of programs don't screen for brain injury. And if it is done, it's usually, have you ever had a head injury is a lot of times the wording we find. And that's really a drop in the bucket of what brain injury can be, as we've talked about with Dr. Fullen in the beginning of the presentation. So a lot of our work too is building awareness of what is a brain injury and how can we ask better questions to identify those individuals. And then also, as Dr. Fullen also pointed out, sometimes brain injury is not treated initially, especially if there's a polytrauma. They're really focusing on getting that person to survive. So if there's maybe a minor injury or a moderate injury that's not life-threatening, but could produce symptoms later, it may not get diagnosed initially, particularly if that person doesn't stay in care long enough, because we do see some folks that either leave AMA or aren't able to go to skilled nursing because of placement issues or what have you. Go ahead to the next slide, please. Thank you. Transportation is a big one here in Maine. It's kind of a little bit of something that I spend a lot of time thinking about in my role, because as we talked about that rural population spread out, it can take you 5 hours to go from the northern point in Maine to a southern point in Maine. So if your only service is in York and you live in Caribou, that could be a huge one time just to get there. And then if you can't drive, you've got to figure out transportation to get there. Gas prices are high, so trying to reimburse somebody to take you. If you have physical limitations that you can't get into a normal vehicle, that can be a challenge. So it's really not unusual in Maine for people to travel an hour or more one way for services. And when we talk about one of the larger symptoms of brain injury being fatigue and overstimulation, that can be a lot to ask of somebody to drive that far for services. So taking that into consideration as we're planning things, trying to make it worth their while to make that trip to go to that appointment, making sure we get done as much as we can while they're there. That's, that they can tolerate. And then our statewide resources. So some of the stuff I've kind of listed all the bad. Now what's going on for the good? What's helping all of this? So with opioids, in 2025, we have these great webinars. We have the summit coming up in July, which will be in Augusta, the Governor's Summit. The MERN group, Maine Reentry Network, I cannot sing their praises high enough. They have been such a help to me as I started this work in making connections and getting to know people. It is a public group. Anybody can join. You can go, search that and it will come up and you can ask for the Zoom link. They meet every Tuesday and it's just such a fabulous group to bounce ideas off, find resources, vent if you need to. They're awesome. Maine Recovery Action Program that keeps a daily updated list of available detox beds in Maine. So it makes it really streamlined to be able to find a detox bed for somebody in need. And then programs like MCD Global really focuses on rural behavioral health workforce. So training those staff to provide those resources in the rural areas. So really focusing on that rural component. And then in brain injury, we have us here at the Brain Injury Association of America Maine chapter, BIAA Maine. We provide a resource directory, which is like a phone book of brain injury resources here in Maine. We have our resource fair coming up Thursday in Augusta, which is like the resource directory come to life in a room. We have like 50 different vendors of different resources in Maine that professionals and survivors and their support systems can come and wander through and talk to people and network. We have about 22 different support groups in Maine. We have an annual conference. We have a helpline, a 1-800 number you can call and be like, I'm not sure exactly even what I'm asking, but here's where I'm at. And we can help kind of guide that conversation and figure that out a little bit and link you hopefully to some resources. The neuro resource facilitation is for those who might need a little bit more longer support than what the helpline is. Helpline's kind of one question, one answer, or a couple. Neuro resource facilitation can last much longer and really have that longer term support to apply for the brain injury waiver, to seek resources in your area, to offer some support to any professionals somebody might be working with. And the great thing about all of brain injury services through BIA Maine is pretty much everything is free other than attendance at the annual conference. So we really try to keep it low barrier. Yeah, go ahead to the next. So the three pilot sites that we've been working on we've been working with Kennebec Behavioral Health with their opioid health home program in Skowhegan and their Respect Me program. And then Aroostook Mental Health working with our residential treatment facility, and Spurwink with their community program and harm reduction. So what we've been doing is trying to follow a formula created by NASHA, the National Association for Head Injury Administrators, in starting with training. So we've done multifaceted training programs and then using a screening tool. So there's a screening tool out there called the OBIS that Maine subscribes to. And if anybody's interested in that, if you can make our resource fair, we'll have somebody there talking about it. You can reach out to me or reach out to DHHS office and they can talk to you about that. But Maine subscribes to the OBIS tool, which is a brain injury screening tool. And it also screens for symptoms, which is awesome, and gives accommodations for those. So again, another thing I can't really speak too highly about. It's just a great screening tool, and it's free. And then we're working on interventions. So making sure that we're supporting them to utilize accommodations that the OBIS recommended, referring them to NRF services for longer support if somebody needs that alongside the substance use services that they're getting, recovery supports. And support info being able to be taken from the OBIS so that the person could take to their primary care physician if they'd like to explore that further into a diagnosis. And then longer term, as we wrap up our pilot, we want to make sure that our pilot sites have the option for this to be sustainable, and keeping that in mind so that they can continue this work even after the pilot. So more Maine updates. I kind of talked about the OBIS already, who you can reach out to, our behavioral health program pilots. We also have a pediatric brain injury community of practice that's going on. So really looking at, you know, the youth of Maine and how we can support them going forward, how we can support the schools supporting them as well. In Maine, brain injury services are really provided by the schools for school-age children. So really making sure that they have the resources for that. And then some of the other programs I already talked about. And then we also just finished, the state finished a neurobehavioral service evaluation, where they had a consultant group come in and really look at what's in Maine for neurobehavioral services and make recommendations going forward. And then to the side is just some upcoming trainings if you want to know more. So a quick case example, and I'll turn it back over to Dr. Fullen. So this is a Maine resident I've been working with as a neuroresource facilitator. He's 43 years old. He had a traumatic brain injury back in 2006. So as Dr. Fullen said, like, you know, your recovery potential, as we're learning, is longer and longer and longer. This gentleman is far further out from his injury than, you know, the original 2 years of recovery that, you know, I was brought up with in the field of knowing. But he still has some great recovery potential, as we've learned over my 2 decades in the field. He does have a substance use history, self-describes as using substances to mask his brain injury symptoms because the substance use was more easily understood by his friends and family. So he would rather say, oh, it's because I drank a 6-pack than I have a brain injury. He had several attempts at recovery, managed to start to apply for the brain injury waiver several years ago, but couldn't stay sober long enough to get the neuropsych screen done, couldn't connect those dots due to insurances, and so forth. So really somebody that was kind of continually following through these gaps. So what we've done is really kind of a multifaceted approach, as Dr. Fullen talked about, really, you know, bringing the whole team together. And so there's the question, as you're looking at this kind of Venn diagram of all these people involved, is there a point where there's too many cooks in the kitchen? And I don't think so. I think as long as the team communicates and tasks are designated so we're not overlapping, and everybody kind of brings their specialty area, we're learning from each other and we're building our skills while assisting this individual. And also, not all of these services happened at the same time for him. You know, he was in the ACT program, and then that was referred out to case management as he got, you know, better. So these have been kind of happening in a layered approach over time as well. And then, you know, keeping them involved as much as we can without overwhelming them, and that's always a balance that we seek. It's kind of always a work in progress. So currently he's been sober for over 90 days. He's living in a sober home. I have seen so much clarity in him as he's become sober, and really trying to make sure he's aware of that. Like, you know, you look better, you sound better, you're remembering more, you're using your tools, really using those, you know, positive affirmations or praise statements to keep him focused on his goals. Working on increasing his natural support system. Brain injury and substance use has this effect of really pushing everybody away. So when somebody's kind of coming out of that, how do we bring that support system back in or create a new support system for that individual? Because they're going to need them when the professionals run out of hours. That's who's going to keep carrying them forward. So we were able to get him set up with a neuropsych. Actually, I think getting it next week, getting set up with a neuro rehab clinic. So really, he's now, 20 years after his brain injury, almost now getting some of the brain injury rehab he needs, but it's not too late. He still can make gains. We can teach him accommodations. We can utilize strategies in his environment. We might not get the recovery if he had gotten it right out of the gate, but we still can get some recovery, and we can make him have a in a situation where he has a better quality of life and more functionality in his life. So really, he's motivated now, he's building self-advocacy skills, and I just can't say, anything bad. He's putting in the effort, which is fabulous. And that's really what it takes, is that village. So that's the summary right there. It takes the village. The more co-occurring challenges, somebody has a larger village. Obviously, we talk about substance use and brain injury, but there's also that overlapping of veteran status or mental health or incarcerated. You can end up with 5 or 6 different co-occurring challenges. So really sizing your village based on that and what that person needs and prioritizing. Professionals with diverse skill sets may be able to fill multiple spots in that role. And then really kind of juggling that with what payment sources and all that good stuff. And building that diverse network as a professional is something I think we all can do, is just continue to diversify our networks so we have a multitude of people to lean on when somebody like this comes into our caseload.
Patty, we had a question in the chat. Can you go over what ACT is again?
Oh, I can't remember it exactly, but it's a very intensive substance use program. Particularly, I believe, if there's behavioral components to that or correction involved programs. I apologize for not knowing the acronym offhand, but yeah, it's a very intensive program. There's an admission process to it.
Okay. Thank you so much, Patty, for sharing all of your expertise with us. Some of those resources are so great. I want to borrow them for here as well. I wish we could have National Resource Bank.
I
All
think
right,
that's the
guys,
ultimate goal, right? Through
yes,
NASCAR.
yes.
That's the ultimate goal.
And that's actually what we kind of want to end with today, sort of like, understanding traumatic brain injury, understanding opioid use disorder, understanding some of the things that make both of those presentations really unique, and what that might look like and how that might complicate things if those two conditions are going on at the same time. And what can you guys do about it? So, we've just heard such wonderful information about not only the barriers, and it's actually helpful to know the barriers. It can, sometimes feel like, oh gosh, that's a lot to cope with, but knowing the barriers can help us really develop a nice action plan. And so let's talk about what that might look like. So if you're, wanting to sort of integrate some of the things you heard about today, where do you kind of start? And so one of the things I really want to encourage everyone to think about is this idea of comprehensive care. Like, what does comprehensive care mean to you? And one of the things that I really think is important about comprehensive care, and this is exactly what Patty said earlier, is there's probably not too many cooks in the kitchen. So get other people involved, but really making sure that you're coordinating care well between different healthcare professionals. And the easiest way to do that is communication. And I have some ideas in a future slide that we can talk about for some ideas about how you can implement that. But also consider incorporating co-located care in your clinic if you have the permissions to do so. So if you're sort of in a exclusively primary care type setting, how can you have behavioral health there? If you're in a substance use or a mental health clinic and you don't ordinarily do brief cognitive screeners, get some training and have like something on hand like the MOCA, so you can start looking for some of these cognitive symptoms that usually are one of the biggest reasons why pure substance use disorder treatment won't really while target someone who has a TBI history, because those cognitive problems will get in the way. And so thinking about easier data sharing between facilities, warm handoffs to help patients transition more easily is why case management is so amazing for people with comorbid TBI and anything. Unfortunately, not everybody can afford case management. Case management services tend to be pretty limited, but this is kind of what I was talking about with the communication piece. If you can promote easier data sharing, for example, asking your facility if you can have a secured email address that is specific that providers can email into, if you could have a, a fax number that you can use for secure communication, if you can have something like a monthly Zoom meeting where providers can get together and talk about shared cases or really just learn from each other, those are wonderful ways to start improving communication across different facilities. And then thinking about if you're sort of trying to develop programmatic changes in order to target something like TBI plus opioid use disorder, thinking about not only having TBI level treatment, so like rehab, and having that substance use treatment, but then also targeting some of the things that kind of, the chicken before the egg. If you can figure out what the first thing was, and sometimes for people with substance use disorder, it is pain management, with opioid use disorder specifically, I'm sorry, making sure you're not leaving out something like pain management, or leaving out something like cog rehab, or leaving out something like CBT for depression, so that you really are making sure that anything that could be promoting that substance use can be kind of taken away. So anytime you can interrupt a cycle, you're in a good position. So also thinking about promoting prevention programs, if you're involved in this industry at all, part and parcel of what we do is treating active symptoms. But if on the side, we can start promoting ways that we can prevent traumatic brain injury, prevent opioid use disorder, is amazing. So familiarizing yourself with things that Patty explained, like some of the education and prevention programs, can be super helpful, especially in your state. Introducing other people you work with to those programs, like, hey, I learned about these great trainings, like, let's go together. They have a free lunch. Anything with a free lunch, I go to. And then really kind of stressing the importance of early intervention. As Patty said, we can have functional gains after traumatic brain injury. Most updated history says 15 years and beyond the date of original injury, with rehabilitation programs, which helps improve people's ability to complete their ADLs and IADLs independently, and as well improve their quality of life. So there is still a chance of recovery even years out. But as she also said, the earlier we can get some of these services, the better. And the same thing is true with any kind of opioid use disorder. The earlier we can target and treat these things, the better. So really just trying to create community awareness. If you're working with individuals with comorbid TBI and OUD, talk about it. Talk about safe prescription practices, talk about alternative pain management that you've heard about, and help get involved in education and public awareness. So the other big thing with any kind of initiatives is making sure that you are empowering stakeholders. So a lot of times when we want to develop programs, or when we want to promote education or prevention programs, the thing that helps that happen is money. And that's unfortunate, and I hate that. I think that probably Patty and I would take over the world if we could, if we could. And we just met each other a couple weeks ago, but the idea is that we are all in this field for a reason. And so we all have the passion for it, we have the knowledge, but what about sharing that and sharing that in a way that'll allow us to do more? And so if you know the stakeholders in your community, typically other providers, policymakers, law enforcement, community leaders, even if it's not tangible money that someone's donating for a big grant that allows you to do a national training, what about someone borrowing some space for a, public awareness initiative that you can put together, where you can talk about cognition and psychological changes after TBI and OUD and make that open to the public. Maybe a local restaurant can donate some snacks, because if you have snacks, people go. Little things like that can help you get the word out. And then of course, making sure that we're not only training other providers and connecting with families and connecting with advocacy groups, but I really want to highlight peer support. I always say this, always looking at the time, like I want to talk more about this, but peer support is so effective in substance use disorders. There are lots of programming where people have mentors, and that really helps them through their recovery long term. We don't have that as much for traumatic brain injury, but we have it in some states. I'm actually one of the people that have pioneered and spearheaded a peer support training for traumatic brain injury and implementing peer support in traumatic brain injury in our state. And it works so very, very well. So if you have the opportunity to learn more about peer support for traumatic brain injury and comorbid substance use disorder, please do. And if you have an opportunity to initiate programming like that, consider it, because people really, really, really benefit from learning from people who've been through what they're going through. And then last but not least, Patty explained a lot about some of the gaps in services that are prevalent in Maine. And one of the things to think about in your sort of community are those gaps, because knowledge is power, and sort of empowering yourself by knowing where the issues are, you can better tackle them. If you are in the position to even start a group therapy for a comorbid TBI and OUD at your facility, I really want to challenge you guys to think about a needs assessment. An easy way to do a needs assessment is just to collect information from the other people at your clinic. How often are you seeing comorbid TBI and OUD? What do you think are the biggest factors that get people who have TBI and OUD and limit their ability to sort of like take in information? Finding out what other people are experiencing anecdotally in their work, as well as what you're experiencing anecdotally in your work, can help you identify unmet needs that are unique to your community and help you really develop something that's targeting some of those gaps. Yeah. As much as you can, collaborate, link resources, get involved in advocacy. There's a lot of TBI advocacy going on this month because it's Brain Injury Awareness Month. But anything that you can do to help with policy changes and advocating for funding works. But again, even if all you can do is potentially starting a group that helps people with adjustment after TBI and substance use disorder, that is life-changing for individuals that have such a complex comorbid condition. And that, I think, is all we have today. We have some time to take some questions.
Dr. Fullen, we do have one question in the chat. The question is from Tanya. She wants to know, what is some feedback around body work, such as acupuncture and yoga, working for TBI patients despite the structural damage that they may have?
That is such a great question. I think complementary alternative medicine is always helpful in different ways for people with complex conditions. If you're thinking about something like traumatic brain injury, anything that is going to augment any traditional medical treatment that someone's receiving, it's worth it to try, especially if it's something that, of course, is safe and that typically falls under the category of safe complementary alternative types of medicine. I will say that I don't know a lot about acupuncture, but I do know a lot about yoga. I love yoga, and it's probably why I'm biased. I would never get acupuncture, so I don't know as much about it. But I will say that we have a couple of yoga therapists here that we actually work with. They do adapted yoga for TBI survivors. A lot of that is chair yoga, and there are a lot of really wonderful things that people who have things like spasticity, have weakness and balance problems, can really benefit from yoga training that is accommodative and specific and safe. And then of course there's all those auxiliary benefits from something like yoga as well. So like improve mood, improve confidence, the opportunity to get around other people potentially that may also have an acquired brain injury, that are maybe struggling in different ways that are similar to your own struggles. And so I think it has a lot of really nice benefits.
I also put in the chat, there's an organization that has a retreat in Maine called Love Your Brain. You can Google them. They have a retreat in Maine every year, and their whole program is kind of built around health, nutrition, activities like yoga, and things like that. And my 2 cents as a rec therapist is like any activity is better than no activity. So really just managing the risks and then enjoy. I've done yoga on the Wii even with clients, and it actually gives them great feedback to see like their balance on the little charts of the Wii, and things like that, and stretching, following directions. There's so many benefits of yoga outside of even just the physical. So there's a lot of cognitive aspects to that as well. So looks like another question. Any specific resources for transition aged individuals 14 to 24 with OUD? Here in Maine specifically, I don't know of any off the top of my head. That would be one that would probably, give a call and we'll talk it through. See, depends on their location in the state, and kind of what exactly we're looking for. But a lot of times what we're doing right now is we're building these resources is, taking it case by case and finding who their support system is, whether it's professionals or natural supports, and supporting them with the neuro piece while they go through the regular standard OUD process, to enhance that with the neuro-informed component. And then the next part of our grant, we're hoping to kind of flip that and bring some of the substance use training to the brain injury providers. So that's kind of where it's going right now. We're kind of in that transition phase ourselves. But yeah, if there's somebody specific you're thinking of, Alyssa, give me a buzz. I put my info in the chat. If that's the Alyssa, I think it is, she knows how to get a hold of me. Chrystal, I don't know if you have any other additional information for that.
I don't. I mean, I think there's some online resources for folks who are in those transitory years, sort of late adolescence, early adulthood. And I think there's some unique like online platforms that are sort of support groups and education groups, but I don't know of any specific program that's geared to that, unfortunately.
I will say the OBIS screening tool, if you don't know that they already have a brain injury but suspected it, it is valid, tested down to age of 10. So that can be used for screening and accommodation purposes.
Yeah, that's a really great tool. I also commend it. Its use. Do we have any other questions?
I don't see any additional questions. So I wanted to say thank you very much to both Chrystal and Patty for your presentation today. I would also like to thank AdCare Institute of Maine for hosting the webinar. And I would also like to thank everyone on the call for joining us today. And I hope everyone has a great afternoon. Thank you.